But I'm going to talk today about a project we recently concluded called Project nGage, which was a randomized controlled trial of a dyadic social support intervention based on young black men who have sex with men, really looking at their social networks and thinking about, can we use their social networks to retain them in HIV primary care. So before I begin, I want to acknowledge that our project was funded by the National Institute of Mental Health, and the PI is John Schneider, who is, and Dexter Voisin here at SSA. I was one of the co-investigators along with Lisa Coons at Northwestern, our research team, and these are the folks who really made it happen. They did the recruitment, they did the interventions, they did the retention of men in the study, and then I'll also declare that I have no conflicts of interest to declare. So the Chicago Center for HIV Elimination. So this is a center that was started by John Schneider. He is the director. I co-direct with him along with Dexter Voisin, Dave Petrak, Russell Brewer. A number of faculty are growing, and the center's really grown. And the goal of the center is to eliminate new HIV transmission events over the next 30 years. So we're really thinking about, the center started in 2011, and through network science, can we eliminate HIV in Chicago by 2041. Now I'll say when that goal first started, it sounded quite ambitious, but as you'll see from some of the data I'm going to present, we're at a turning point in the epidemic where a lot of people are starting to talk about HIV elimination and what that might look like. But we particularly focus on social networks. And so we think about the networks of people that folks who are at risk for or living with HIV are embedded in. And we think about networks in lots of different ways. So we don't just think about the folks who are in them in terms of their romantic or sexual partners, their friends, or their family, but we also think about different characteristics of the network. So we think about the emotional characteristics, what kind of support is available to someone in their network, the relational characteristics, how are all of the different people in the network related, and also contextual factors. So we think about substance use in the network, poverty in the network, criminal justice involvement in the network. We really try to think about networks at multiple levels. And within CCHE, we offer a number of services. There's a couple folks here who work in CCHE, so you know this work well. We do case management, HIV counseling and testing, linkage to care for people who test positive, or relinkage to care, re-engagement in care for folks who have dropped out. Partner notification services. We're now offering pre-exposure prophylaxis. We have a number of projects that are thinking about incarceration and criminal legal system involvement. We have youth engagement and leadership, a drop-in program, house ball community events, substance abuse. You know, we think about lots of different things. And then we have a lot of research that is focused specifically on retention and care. So Project nGage, what I'm going to talk about. We have Project Work, which I'm going to talk about a little bit at the end. Kiara Jones is here, who's a student at SSA and also works at CCHE and is our main interventionist on Project Work. We also have Partner Services Prep, which is another retention and care intervention. So we're really thinking about retention and care. So in terms of where we're at nationwide with the epidemic, the past couple of years have seen a big change. So for a long time, we were about 50,000 new infections each year, holding stable. We can think of that as a success in terms of not going up, although within that 50,000, there were some groups for whom HIV was increasing. But we've also just had, it's been stable for a long time. But until recently now, we've seen that we've dipped down now. We have about a little over 39,000 new HIV cases in 2016. This data comes from the CDC, and we see the epidemic among black men who have sex with men, where we'd seen an increase, that's stabilizing. It's gone down among women, but we're still now seeing increases among Latino MSM, so really thinking about how do we keep our eye on the big picture and knowing that things are going to shift over time. But you know, the trends, the progress has been uneven. And so although infections have been stabilizing for black men, black, gay, and bisexual and other men who have sex with men continue to be disproportionately impacted. So they represent 12% of the US population, but 44% of new infections. And the epidemic has continued to focus on gay and bisexual men. It'll be interesting to see over the next few years if we see increases in injection drug use, given where that's been over time. But even as we talk about elimination, you know, a lot of folks, we need to remember that this is a dynamic epidemic, and we can't I want to say fall asleep, but we have to be vigilant. We have to remember the earlier days of the epidemic and that things change because this is very much based on social context. So in Chicago, yes, Kevin?
When the women statistics were going down, is that all women?
That's all women, but if you look at racial disparities within women, you see similar to men, which is that black women and Latino women are disproportionately affected, with black women carrying a higher burden. So in Chicago, from the Chicago Tribune on December 1st, posted a story utilizing those recent data from CDPH, where we've seen a record number of low cases in the city, the lowest cases in 26 years. And this is due to a number of factors. So it's about a 55% decline, and they attribute it to the Affordable Care Act, right? So 12,000 people in Illinois who are living with HIV were able to receive health care coverage under the ACA. We have treatment as prevention, so now if you are diagnosed as HIV positive, you are immediately started on medication. You no longer wait for your viral load or CD4 count to reach certain levels. And we know that if we can get people's viral load down to undetectable, so there's very small trace amounts of the virus, it is essentially untransmissible. So you're starting to see this U equals U, undetectable equals untransmissible. And then we have pre-exposure prophylaxis. So for folks who don't know about that, it's a single pill that's an antiretroviral medication that you can take on a daily basis. And if you're 100% adherent, it can confer up to 92 to 99% protection if you are to come into contact with HIV. So the field is really orienting around treatment as prevention and pre-exposure prophylaxis as ways to end the epidemic. But we also know that progress is uneven. And so in 2016 in the city, black men accounted for about 59% of new HIV cases, higher rates than both Latinx men who have sex with men and white men who have sex with men, and that it continues to be an epidemic that is affecting young people. So people talk about HIV as a disease of adolescence and young adulthood, and that's very much the case nationwide and here in Chicago. And we also know that when we look at other data, black men who have sex with men are less likely to be virally suppressed, and they're less likely to be on PrEP, and they also experience significant structural barriers. So we want to think about the context in which men are living. So this is just a map of what it looks like in the city. What's nice here is that this is also overlaid with high economic hardship from 2014. So you can start to see that there is overlap between those high rates of poverty and higher rates of HIV infection. But in Illinois, we're now talking about getting to zero. So what does that mean? So the goal is to eliminate HIV in Chicago by 2030 or earlier. And they're doing mathematical modeling, and they're talking about if we can increase the current rates of PrEP use and HIV treatment by 20%, we can essentially potentially get to under 100 new cases in Illinois by 2027. So that's 14 years earlier than CCHE's goals of 2041. But a lot of work is also focusing on 90-90-90. You may have heard this term. Can we get 90% of people who are living with HIV to be diagnosed? Can we get 90% of those diagnosed linked to care? And can we get 90% of those in care virally suppressed? And I believe Seattle has been able to achieve this, and other cities are working to achieve it. But a lot of people are focusing on what we call the continuum of care. So the continuum of care just refers to the number, similar to the 90-90-90, the number of people who are diagnosed, the number of people who are receiving care, the number of folks who are retained in care, and then the number of folks who are virally suppressed. And I'm going to show you a couple of different continuums, and you're going to see this pattern kind of repeat. And so this is based on national data from the CDC for 2014. And when we start to look at it by race, ethnicity, and age, we start to see those same differences that emerge in the broader epidemic in terms of the epidemiology. So we can see that African Americans and Latinos have similar rates here of engagement in care and kind of poorer rates than their white peers. And we see this in a number of studies too, based on different cities. And then again for age, right? So we see that younger folks have poorer outcomes along the continuum of care than do their older peers. In Chicago, this is data from the Chicago Department of Public Health. It's a little hard to see, but you can kind of see the number of new HIV cases, the percent of people who are linked to care within 1 month, and then they kind of go 3 months, 6 months, 12 months. So you can see an improvement over time. and then the number of folks who are accessing care, and then they focus on retention and care with at least 2 visits, 3 months apart. Now, ideal retention and care is 4 visits per year, so some folks will think, so this is 40%. If we took it up to 3 visits per year, this would probably look a little bit worse. So we have a lot of work to do in Chicago to think about how to retain people in care. And then for viral suppression, only 48% of folks are virally suppressed. So we've still got quite a bit to go to get to our 90-90-90 levels. So the continuum of care for young black men who have sex with men, this is data from John Schneider's study, You Connect, where they actually did HIV testing in the study, and then were able to follow men over time to see what their linkage was. And you can see this same trend. So 72 diagnosed, 60% linked to care, 49% retained in care, 36% on ARV, and only 31% with suppressed viral load. So again, there's a lot of work to be done here. So I want to talk about why we focus on retention in care. So we see retention in care as a key intermediate step in the continuum of care. And for folks who work in health and social services, you know that if someone is coming to care, you can connect them to other services, right? You can do substance use screening and referral, mental health screening and referral. You can connect them to other resources. We can do chronic disease screening. We know that HIV has a lot of other effects in the body, so we want to watch out for that. Being able to maintain HIV primary care and medication management, and just people who are engaged in medical care tend to have better health outcomes in general. And the research literature is pretty clear that missed appointments, so not going to your regularly scheduled HIV care appointment, is associated with virologic failure and with death for patients. So we really see it as an important factor that if we can get people into care, we can deliver a lot of services and interventions to them. So to date, there have been few randomized control trials specifically focused on retention and care for young black men who have sex with men. And in general, when you look at the literature, you see that there are about kind of 5 different strategies. So there's peer support groups. Someone may be recently diagnosed with HIV and maybe offered a peer support group where they will come and talk to other people who are living with HIV. There's a lot of multimodal peer outreach or intensified case management programs. Those interventions have generally been effective, but there's a lot of different parts to them. So we don't know which part is most important and what works, and sometimes they can be program, resource, and staff dependent. A lot of work is starting to look at peer health navigators, and the research on that is mixed. Sometimes it's effective, sometimes it's not. And similarly for financial incentives, right? What happens if we pay people to stay engaged in care? And again, the research literature is mixed. But for all of these, what's really interesting is that we're relying on external supports, right? We're creating supports within the clinic to bring people into care. We're giving resources to people, and I think the resources piece is very important, and clinics should be supportive, and we should offer lots of things to people who are struggling in lots of different ways, not just for folks who are living with HIV. But there are questions there about the long-term sustainability, right? And in particular, what happens when resources go away, then do programs go away? So within these programs, we also see that social support is thought of as something as non-human support, external resources, when in many of our lives, social support, right, consists of the people that we are connected to, right, that provide us with closeness, warmth, friendship. They may also provide us with resources, but they do lots of different things. And those kinds of social support tend to get overlooked, especially for people living with HIV and for LGBTQ populations. And I'm going to talk about some of the reasons for that, but there aren't a lot of interventions that specifically focus on family, friends, partners, and mentors, people who naturally exist. And yet we know from the research literature that that kind of social support is critical for better outcomes for people living with HIV as well as other chronic health conditions. And then from a lot of the social psychology literature, we know that actually the messenger who delivers the message is actually quite important. So if you have 2 people, they can say the exact same thing. The person who is perceived as more trustworthy, more accessible, they are perceived as having greater expertise, and that message is taken in more readily than the person who is not as trustworthy. So if there's a relationship where there's already trust existing, it can be quite influential or has the potential to be influential to involve that person. So the reason, and this is a very good reason I want to talk about this, right? So why aren't these endogenous supports activated and utilized in routine clinical care? And a lot of this has to do with fears of stigma and discrimination. So people talk about HIV being a chronic disease, just like any other chronic disease, but there's still a lot more stigma against HIV than there is, like, say, diabetes or other chronic conditions. And in the in the Project nGage data, we have a paper that actually looks at stigma and discrimination among men in the study and did find that higher levels of perceived and internalized stigma is associated with higher viral load. So we know that it plays a very powerful role. But we also know that social networks are emerging as a key explanatory factor in the HIV epidemic, and people are really starting to look at what does support look like in the network, what about people's sexual networks, how do we think about stress in the network, what does viral load in a network look like. But there aren't a lot of social network interventions, but we really think about social networks as a really great way, a flexible way to think about how to identify and activate and engage someone in care, because we avoid a priori assumptions about who the most supportive person is. We can select based on that supportive function versus their role, and we can tailor it for each person. So as we were thinking about doing this work in the context of Project nGage, we did a small pilot study in a federally qualified health center where we worked with 14 young Black gay and bisexual men who were recently diagnosed with HIV to try to understand what their social networks look like and what disclosure in the network look like, right? So this whole idea falls apart if you work with people and you find out that they're not actually disclosing their HIV status to folks in their network, or that when they do, those relationships fall apart and they're not able to get support and closeness. So I'm going to talk about this sociogram procedure a little bit later, but basically we have a procedure where we ask people to list and draw out the people in their network. And there's different ways we do that, but for this study we asked them people who you can rely on in a time of need, and we did this at 1 month and 9 months post-diagnosis to see what the networks look like. And then you ask them questions. Well, who is this person? What is their gender? How do you know them? Do they know your sexual orientation? Do they know your HIV status? And we developed this kind of algorithm to identify the most trustworthy or reliable person. And what we found was that 100% of folks had disclosed the HIV status to at least one support confidant 1 month after diagnosis. And the support confidants they tended to list were male friends, sex partners, sisters, mothers, and female friend. And so let me show you what this actually looks like. So this is some of the figures from that study. So in this panel A, you have someone, this is the young man who has been recently diagnosed with HIV. These folks in the outer circle do not know their serostatus. And then 1 month later, you can see that person A, they have disclosed to. And then this dashed tie means that this relationship here, 1 month later, is no longer present, and we've moved this person outside of the circle. So it's a really visual way to kind of play out where people are in the network. And then here you see at baseline, right, so this person has just been diagnosed with HIV. None of these folks know their status. 1 month later, person B, they have disclosed to. 9 months later, A, B, and D. And then we also look at whether or not these folks know each other as well. So we're really trying to understand what these dynamics are like in the network. But some of this early work suggested that this was a feasible approach. So we wrote a grant application, and we were funded to do this feasibility, acceptability, and efficacy trial, and that's what I'm going to talk about now. So we wanted to understand, is this method feasible? Is it acceptable? And so some of the questions, right, are there sufficient stable support confidants in networks? Support confidants are what we call the folks in people's networks. And I will refer to the young person in the study as the index. I know it's kind of not, it's researchy language, but it's the best we've come up with so far. Can a network approach identify the right support confidant? Can support confidants be engaged in an intervention in the index's care? And does engaging a support confidant actually affect the outcome we care about, retention and care? And so we have a number of papers that have described the intervention. Our outcome paper is out, which is here, and I'm going to talk about those results now. So I think I've talked about this, but we're really thinking about HIV. Living with HIV requires deep and persistent social support. And it's the type of social support that is usually only available to folks from people they already know. And we know that that kind of support is associated with better health outcomes. We know that these folks exist in young men's lives. and we think we can engage and harness them. And we think that we can then deliver evidence-based guidance to them in a way that will help them to keep their friend or loved one engaged in care. So for this particular study, we partnered with 5 federally qualified health centers here on the south side and conducted primarily face-to-face recruitment and then also used flyers. To be eligible to enter the study, you had to identify as Black or African American, be between ages 16 to 29 inclusive, assigned male sex at birth, and speak English. You'll see from this data, we did have 2 transgender women who enrolled in the study for analytic purposes because there were only 2 that were dropped from the analysis. But that is an area that we're thinking about as well in the future. They had to report self-reported anal or oral sex with another cisgender male in the past 2 years, be living with HIV for more than 3 months. And some of that early work we did, we saw that that 3-month period was actually also quite chaotic. Right? People were really adapting to their diagnosis. They might be going to multiple clinics looking for a doctor. And so that's not a really good time then to intervene with folks. They had to own a cell phone not shared with other folks and have 1 or more persons in their network who knew their status. Standard things around consent. We had a waiver of parental consent for folks under age 18. And we did, at the baseline data collection, we did this big sociogram procedure, and then we randomized folks to either study condition. So you can see here what our consort diagram looks like, which just kind of takes people through the study. We assessed 161 folks, 55 were excluded, 53 of those did not want to participate, 2 did not meet inclusion criteria. We randomized 106, and I'm going to talk about this. We did have some folks who just didn't receive the intervention. And kind of these are the reasons why. And we had some folks who were lost to follow-up, and I will show you what that looks like as I move through some of the data. The control condition, because we were in multiple clinics, it was just whatever treatment as usual is like in each clinic. So there can be some variability there, but this is generally what clinics said. They offer mental health services, medical case management, psychosocial support, resource counseling, and then routine medical care and HIV primary care. For our intervention, there are 3 primary components. So the first one is the selection and invitation of the support confidant. We have a single session that consists of individual and dyadic modules, and then we deliver booster sessions to the index and the support confidant. And I'm not going to talk a lot about the theoretical and conceptual background, but we use social network diagrams in theory. The actual intervention content is based on the information, motivation, and behavioral skills model. We do a lot of cognitive behavioral therapeutic work around identifying barriers, problem-solving capacities. The interventionists use some motivational interviewing techniques, and then this is all occurring in the context of how we think about social support. So there's lots of different components. I'm happy to talk about it more at another point in time. It's also well described in the 2 manuscripts that describe the work we're doing. In the sociogram procedure, what we did is we asked folks to please identify people in your life with whom you share personal information with and can count on in a time of need. When we say personal information, we mean private things about yourself that you might not tell everyone. And so that's how we prime people to think about who are the people that are close to you. And then they can list up to 10 folks. They can list their names, nicknames, initials, and we take those first 5 because research suggests generally the first 5 are going to be the closest, and we use that to fill out the sociogram with them. And then we ask them these series of questions. Who is this person? How are they related to you? How old are they? Do they know that you're gay or bisexual or have sex with men? Do they know your serostatus? And we get all of the information. And then we also ask, how trustworthy is this person? How likely are they able to support you in the next 12 months? Have they betrayed you in the past 6 months? How stable are they? Has substance use negatively affected their life in the past 9 months? How often do they move to try to get at the stability? And then we ask how are all of these people connected to one another? So we really try to get an understanding of who these 5 people are. And then we go about selecting the support confidant. Now we have an algorithm where we actually assign people different scores based on the answers they give, and then the algorithm kind of spits out who the person should be. And sometimes there's a match between what the algorithm says and what the support confidant says, and sometimes there's not. There are some hard stops for us, so they have to know their sexual orientation and serostatus. The index has to believe and report that this person will not disclose that information to someone else against their will. And they should not have betrayed the person in the past 6 months. We let the index choose for the most part, unless we also have an abuse screener. We screen for abuse in the relationship, unless that screen is positive, right? And then we explain to the person that they're not a good candidate and why. And all of this is also explained in the consent form, so folks know this going in. But once that support confidant has been identified, the index then calls them and engages them. And they just have to be, the support confidant has to be over 18 and speak English and own a cell phone not shared with other persons. So fewer inclusion criteria. And then once the support confidant is engaged, the consent form informs them that we're also going to be doing regular screening for abuse or strain in their relationship, and that if abuse is reported by either person, we will discontinue them from the study and then have to offer supportive, legal, or other services as is appropriate, depending on what information we find. So what our intervention is. So it's a single session intervention that is a little bit over an hour and a half. Sometimes they go up to 2 hours. It really, Chiara can tell you, the one we have right now, I think we said was 90 minutes, and it's probably closer to two hours. So we start off with a joint index SC session where we bring them together and we talk with them about the importance of HIV primary care and social support for people living with HIV. And then we have this client-centered discussion between the two of them that is focused on what social support looks like in their relationship. So we get them to start talking with each other about how do you support one another? What happens with one of you is sad? What do you do? What's been helpful to you, for you from the other person to really try to get them to start talking about this. And then after that conversation, the idea was that the index would then leave and go to their HIV primary care appointment. That requires a level of perfect timing that we have not been able to achieve. So usually what happens is that the person goes out and waits in the waiting room for 60 minutes while the support confidant continues to meet with the interventionist. And then during that session, when we think back to the information, motivation, and behavioral skills model, which tells us if you give information, it increases people's motivation. We give then specific information on HIV and AIDS, helping people to understand what is HIV and what is AIDS, and that these are different things. We talk a lot about the importance of retention and care, and we talk about common barriers to care. And then the interventionist has a conversation with the SC to identify and problem solve potential barriers to providing social support to index. So the index person. So while we know that social support is very important, we also know that our close relationships sometimes are also our most conflictual relationships. So we want to have a conversation with the support confidant to understand, well, what might get in the way of you being able to provide them with care? What are the stress points in your relationship? And then we bring them back together for a final joint session where we talk about potential barriers to care. So we ask them, what are the things that are likely to get in the way of you coming to your next clinical appointment? And so they list out maybe 3 to 5 things or more. We rank order them, right? Which one is the most likely to happen to least likely to happen? And then we start to generate strategies to overcome those barriers. And then specifically what the index can do if that barrier comes up, and then how they will get the support confidant to help them to overcome that barrier, and then they do some behavioral practice together. So we try to promote their relationship, their self-efficacy to address problems, and their problem-solving capacities and skills. And then after that, we do booster sessions. So immediately afterwards, there's a booster that's sent. All of the boosters are done via Google Text, so it's actually Chiara or someone else typing. But usually on the text phone or sometimes on the telephone, because the texting can actually also get quite long, which can be really hard for index and support confidants to stay engaged in that long of a text conversation. But we boost at regular intervals. We focus on that care and support plan, so we summarize everything that happened in that session. We just want to remind you, this is what you can do. If any challenges come up, we problem solve with them. We stay focused on retention and care. We screen for abuse or strain in that relationship. And then there's also just general chatting that goes on. We're starting to look at all of those text messages and boosters now and kind of analyze them. And there's just a lot of social interaction and exchange that goes on with both the index and the support confidants. I'm going to talk a little bit more about the boosters, but we had a 74% success rate with the index men in terms of delivering the booster when it was scheduled, and a lower rate for the support confidants, about 58%. So the leading reason for the missed boosters was a change or a discontinuation of cell phone numbers. So a little over 50% of cell phone numbers changed or were discontinued during the course of the study, and up to 6 times for some of those participants. So when we think about relying on phone, and when we also think about many clinics usually rely on phone contacts to stay in contact with patients, we have to think about other things. So we're starting to do this in some of our other work. We're thinking about Facebook, Instagram, lots of other different ways to get in touch with folks, especially young people. So I won't talk too much about our data collection, but all of it was data collected all via REDCap. Folks can enter their own answers into the computer directly for sensitive questions, particularly around their sexual behavior. The primary outcome I'm going to talk about today is retention in care, which we defined as 3 or more HIV primary care visits in the prior 12 months. So it means they just missed 1 visit in the prior 12 months. And that data was extracted from their medical charts. I'll also present the results on self-reported medication adherence and viral load, but that won't be the focus. And then I'm going to talk about the feasibility and acceptability, which is both kind of quantitative and qualitative data we have. So our analytic test, we did an intent to treat analysis, so we're looking at outcomes even for folks who dropped out of the study. Today, I'm going to primarily focus on logistic regression. Because this is a efficacy study, it's small. We only have 98 folks, so at the bivariate level, if it was statistically significant at less than 0.10, we entered it into the multivariate model, and the same for looking at viral load and adherence. So let me tell you a little bit about who these folks are. So 98 men all identify as Black African American. And these are the study conditions. I'm sorry, this is the control group, and this is the experimental group. So about 24 years of old, about half of the sample in each group is working. You can see that this is a group that, in terms of education, folks have a high school or less than this, I'm sorry, this is supposed to be less than high school. This is high school or GED, some college or other school. The network degree is the number of folks they had in their network, whether it was 1 to 3 or 4 to 5. And you can see that disclosure in the network is high, right? And now some of these, if you have to remember, this is essentially 53 folks and 45 folks. So we're talking about small numbers here. So some of these differences might look different, but when you have that small n in each cell, it's not statistically significant. We think if we had a larger sample, we might have been able to see some of those differences. Randomization is supposed to account for these, but we did have some differences, and so I will talk about that. Let's see here. So this is just here the time since diagnosis, 1.8 versus 1.6 years, whether or not they'd been retained in the prior year. And most of the folks, we have a little bit of a ceiling effect here, is that most of the folks are actually reporting high retention in care. Most of the sample is not virally, or a little over half of the sample is virally suppressed. And then here for condomless anal sex, we did have, despite randomization, 33% of men in the experimental condition compared to 15% in the control condition reporting having condomless anal sex with another man of unknown 0 status in the previous 6 months. So our final analyses control for all of these factors in addition to some other ones. So in terms of the support confidants, you can see here these are the folks that were selected to be support confidants in the study. So the majority of them were friends, followed by mothers and sisters, romantic partners, and this other category. And that was a neighbor, cousins, and older mentors. So someone included a pastor, someone else included a father figure. The majority of the support confidants also identified as African American were slightly older than our participants, so 30 years old compared to the mean age of around 24. And then the majority were female, so a little over half were female. And in terms of their sexual orientation, though the majority identify as gay and bisexual, followed by straight, and some folks reported being unsure or they didn't quite know what their sexual orientation was. And comparable rates of education among the support confidants. And then we asked questions to get at kind of stability in the network, and we saw that about 9% of the named support confidants had substance use that negatively impacted their life at least one time in the last 6 months. So I'm going to talk about the efficacy data first. So this is the results from the bivariate or the univariate analysis. And so this is our experimental condition, whether you were assigned to the treatment as usual or Project nGage. So at the bivariate level, this is the 2.39 compared to the control group. Those folks who were randomized to Project nGage were 2.39 times more likely to be retained in care, but this is at the 0.10 level. Age was a significant correlate of retention in care, which parallels larger data that younger men are less likely to stay engaged in care. And this was the only kind of network variable that was significant, was that the level of betrayal of trust in the network was significant, again, at the 0.10 level. And then not surprisingly, when we think about past behavior as being the best predictor of future behavior, their prior retention in care. Yes?
I'm just curious how you all defined betrayal of trust, because that just seems like what I think of as betrayal of trust might be different than what he thinks of as betrayal of trust, and kind of how you quantify that.
We ask them, has this person betrayed your trust in the past 6 months? And they say yes or no. So they get to define it. Yep. And that's what we're also finding in the qualitative data right now as we dig through those text messages where I'm going to talk about there were withdrawals of different support confidants where the index said, I no longer want to participate in the study with this person. And they are mostly around these kinds of betrayals or where the relationship, particularly in the friendship category, moves from friendship to sexual back to friendship, or one person expresses feelings and the other does not return them. So those kinds of things. So I think that it's useful to try to understand what's going on there. Okay. So I'm going to focus on my final results now. So these factors were all entered into the model, as well as all of these other, I think there's 20 to 25 different factors that are controlled for in the final model. But what we saw was that folks who were randomly assigned to receive Project nGage were 3.01 times more likely to have had 3 medical visits in the prior 12 months than were folks who were assigned to treatment as usual. Although you see here we've got a wide confidence interval. And then again, age is significant. As age goes up, folks are more likely to be retained in care. The betrayal of trust was not significant, and being retained in care in the prior 12 months was again significant. So it was nice, though, to see that we found an effect here above and beyond prior behavior. So we're trying to better understand this now, and we're also trying to really understand the feasibility and acceptability. Because it is feasible and acceptable, but there are some caveats and limitations. Harold?
I'm trying to get a sense of that odds ratio, that 3. Like,
Yep.
What does that translate into, like if I had percent, the incremental difference in retention if I have a treatment group and a control group? Is it 10 percentage points, or is there some?
I will get back to you on that, what that actually quantifies for in actual visits. And I'm going to show this data in a second, but I'll talk about this now. So we talk about retention in care, and the intervention focused on retention in care. But when we looked at self-reported adherence, there was an effect. But when we looked at actual viral load, there were no differences, right? So so that's an important thing to think through. Just a little bit on the feasibility and acceptability. So these are the booster completion rate for the different support confidants. So mothers were the most stable, and we were able to complete more boosters for them than for other folks. And the young men said, I really rely on my mom. She's very supportive, although some said, my mom is over-supportive. She's over-involved. And you can think about a mom particularly having more investment in her son's treatment outcomes than another kind of support confidant. But there was overall low conflict in these relationships. But when we talked to the moms and asked them what they were going on, they were struggling with a lot of demands and challenges. So they talked about, I work full-time, I'm managing my health, I'm caring for grandchildren, I'm doing lots of other things, right? And I'm also supporting my son. For romantic partners, that was the next highest completion rate. Those relationships were close and supportive and fairly stable. But people did report issues around trust and monogamy concerns, and then there was one breakup over the course of the study. For friends, so friends were the #1 type of people chosen as support confidants, And they said, you know, it's really wonderful. My friend's very close. We have shared identities, often around sexual orientation, and also oftentimes around serostatus, so that young men can talk to other young men about what it means to live with HIV. We can remind each other to take our meds, to stay engaged in care. But those relationships proved to be pretty volatile. So we had high rates of phone disconnection and changes here. A lot of folks moved out of state, and high turnover. So 7 of the index men during the booster sessions when we contacted them said, I no longer want this person to participate in the study with me. Now, so we would discontinue the support confidant. We would continue to follow the index. And then sometimes those friendships would reconnect, right? So we're able to kind of look at that data. So we're trying to think that through now. And then for sisters and female relatives, those were strong and constant support. Again, the phone and the moving. And then I think maybe 80% of the sisters also became pregnant during the course of the study. So they're trying to support their brother, but now they're also starting their own family. And then for the other folks, which were the mentors, the pastor, the father figure, they were stable and supportive, but we had the lowest rate of booster completion for this group. And it was because they were mentors and leaders in their community, and they're supporting lots of other folks. So they're not just focused on this young person. One of our main concerns was whether or not there would be support confidants. So less than 2% of the folks we screened didn't have a support confidant. And when we asked folks about what the intervention was like, I wanted to bring in some of those voices. So these are each member of the dyad. So the support confidant here says this was informative. It gave us more insight about relationships and what you can do to improve your relationship. And the index, it's helpful, it's informative. You can tell you are building support. I feel like this is more than a study. It's more long-term and it's helping our relationship. And similarly here, the support confidant said, I like the idea of you working with John, helping him find the light, the idea of you taking time to let the other person talk and listen to the person so they talk to each other. We give them that space. You didn't just run through yes or no questions. I got a chance to do what I do with my psychiatrist and talk things through, and you're going to put $50 in my pocket. We had a $50 research incentive. And you can say he gets a good vibe and a feel, and the index says, I like that you made me think and talk. There was no judgment here. I didn't feel judged at all, and I appreciated that. Yeah. Okay. So what were our takeaways? So, you know, this was a feasibility and efficacy and acceptability study, and we saw that, yes, this is feasible, it's acceptable, and it's efficacious, right? Support folks exist. They can be engaged in care, and that engagement is having some sort of impact on retention in care. But as I previously mentioned, we did not see any results for viral suppression. And viral suppression is going to be key when we talk about eliminating HIV in Chicago and beyond. But it's also not surprising that we didn't see retention in care, because that's not the content we emphasize in the intervention. Sorry, on viral suppression and adherence. We really drill down on retention. But when we think about that continuum, that also suggests that focusing on retention and care is not sufficient, right? We need to think about what else has to be added. And again, thinking about what are the additional supports that younger men need in terms of age and developmental considerations to navigate what are very complex systems and to navigate what it means to be living with a very complex disease. These dyadic interventions, I believe in them. Almost all of the intervention work I've done has been dyadic, but it is really difficult to schedule 2 people, as Kiara can tell you. And then there's a lot of chaos and struggle in both this young man's lives and the folks that they're choosing to engage as support confidants. There are relational challenges, there are very real financial challenges, there's mental health struggles. Some of the things we're pulling through our qualitative data right now is talking about when we go to call someone and we're learning that they actually have been hospitalized for mental health or for a suicide attempt. So how do we think about being more thoughtful about integrating mental health treatment or referring out? And we're starting to think in our group about what does it mean to support the support person. So we're engaging a support person to support someone living with HIV, but the support person might also need some resources directed towards them. And that gets to be a very complicated intervention and program very quickly. So we're thinking about kind of the labor intensity of it, scalability and cost effectiveness issues. And then in terms of kind of some of the limitations and next steps, this is a convenience sample. So we were in 5 clinics here in Chicago. It may not generalize to other settings and populations. What I mentioned at the beginning, both groups had pretty high levels of baseline retention, ARV adherence, and viral suppression. So we could have gotten different results with a community-based sample that is not actively engaged in care. But we did see that our intervention was powerful enough to still generate a difference above and beyond kind of baseline retention in care. We were not powered to look at the pathways of influence, so we don't know why this worked. Did we reduce stigma? Was it increasing social support? Was it motivation? We're hoping to be able to explore that in future studies. And we also don't know if these effects are going to last beyond 12 months, right? We follow folks at 12 months. We don't know where folks are now. And then thinking through, can this model be used to address other steps in the continuum of care? It will have to be changed, right? If we can already see that in our data. If we want to think about ARV adherence and viral suppression, but what about PrEP? And are there effects for support confidants and other network members? We collected very limited data from the support confidants. In the current study we have now that Kiara works on, Project Work, which stands for Wellness, Encouragement, Respect, and Kinship. And it's for HIV-negative Black men who are on PrEP to stay retained in care. We're collecting a lot more data from the support confidants. We are seeing some support confidants who are asking questions about PrEP and want to be linked to care themselves, so thinking about that network intervention spreading. We're seeing high levels of feasibility and acceptability, but similar challenges around the scheduling issues in particular. And there's a study, though, that just came out from the HIV Prevention Trials Network that looked at social network support, so similar to what we're doing, but at the network level. And they found that it was associated with lower odds of seroconversion over the course of the study. So we know that social support is doing something important. And so we're starting to think about this, not just for treatment, but also in the context of prevention. But this question of how do we integrate and scale up organic social supports in routine clinical care, given all of the constraints. So that's all I have, and I welcome questions, comments, whatever you have. Jean.